Thank you very much. I appreciate the invitation to participate in this important symposium on the roles of hyalocytes in health and disease. Hanover was the first to describe the existence of hyalocytes, credited in 1840, and Schwalbe in 1887 described these as Wanderzellen to denote their similarities to macrophages elsewhere in the body. But it wasn't until 1964 that the term hyalocytes was applied to describe the mononuclear phagocytes located at the vitreo-retinal interface. And since then, many investigators have employed this term, although recently non-invasive investigations in live humans has resulted in the use of terms such as macrophage-like cells of the retina. But hopefully, this symposium and the work of the participants in this symposium will reorient these investigators to use the term hyalocytes, which is more correct. Dark field slit microscopy demonstrates the existence of hyalocytes as highly refractile spots in the posterior vitreous cortex. In all of these specimens, the outer coats of the eye were dissected, and a slit lamp was used to create a horizontal optical section through the vitreous. The anterior segment is below in all of these images, and the posterior pole is above. The upper two images are from children, and the lower two are from middle-aged adults. The arrows indicate the highly refractile spots embedded in the vitreous cortex of these intact vitreous bodies. Phase contrast microscopy demonstrated that these spots result from mononuclear phagocytes that are located in a monolayer originally believed to be 50 to 75 microns anterior to the ILM, but we now know that these can be located anywhere from 10 microns to a few hundred microns anterior to the inner limiting membrane of the retina. The transmission electron micrograph on the right demonstrates the embedding of these cells within the dense collagen matrix of the posterior vitreous cortex, because you can see the collagen fibrils both anterior and posterior to the location of this hyalocyte in a human specimen. Swept source OCT does have the ability to demonstrate cells at the vitreo-retinal interface that appear to be embedded within the posterior vitreous cortex, and I look forward to many more studies of this phenomenon using this new imaging technology. But I'm most excited about the development of adaptive optics OCT, where coronal plane imaging has demonstrated the presence of cells at the vitreo-retinal interface. Although these have been described as macrophage-like cells of the retina, they're actually hyalocytes embedded in the posterior vitreous cortex. It's also interesting that Hammer has documented slow migration of these cells, highly reminiscent of Schwalbe's description of these cells as Wanderzellen. Rich Rosen's group in New York has looked at diseased eyes with coronal plane imaging using adaptive optics, scanning laser ophthalmoscopy, and has demonstrated that in diseased eyes from proliferative diabetic retinopathy in the upper panel, central retinal vein occlusion in the central panel, and open-angle glaucoma in the lower panel, the hyalocytes appear to be plumper and larger. The role of hyalocytes in immunology has been investigated by Sakamoto and colleagues in Japan, but Professor Lange is to be credited with bringing this into the modern era, and I won't go into it because we're going to hear some presentations from his group who have done excellent work in defining the role of hyalocytes in immunology. To understand the role of hyalocytes in pathology requires an understanding of the underlying anatomy, and specifically an understanding and an appreciation of the multi-laminar structure of the posterior vitreous cortex, as has been demonstrated in monkeys with immunohistochemistry by Greg Hageman, That appears in the images to the upper left. OCT on occasion can identify lamellae in the posterior vitreous cortex of humans, and it's important to appreciate that during anomalous posterior vitreous detachment, when the vitreous body separates away from the retina, there can be incomplete separation with splitting in between the lamellae of the posterior vitreous cortex, a phenomenon known as vitreoschisis. So when there is liquefaction without dehiscence at the vitreo-retinal interface, the splitting can result in vitreoschisis. And if this split occurs anterior to the level of hyalocytes, these cells are left attached to the retina, and in the posterior pole can induce centripetal tangential traction, causing a macular pucker. In the periphery, vitreoschisis, leaving hyalocytes attached to the retina, can be an important step in the pathophysiology of proliferative vitreo-retinopathy, as emphasized to us by Van Overdam. I look forward to the presentation by Ricardo Schumann later in this symposium, who will describe the proliferative vitreo-retinopathies that result from anomalous PVD with vitreoschisis and the role of hyalocytes in these diseases. Patients with macular pucker have a high prevalence of vitreoschisis. Spectral domain OCT identified this in 53% of eyes, but I predict that swept source OCT and other imaging modalities will identify for us that the prevalence of vitreoschisis in eyes with macular pucker is actually higher than 53%. The OCT up to the left was in a patient with macular pucker on whom I operated, and the specimen was analyzed histopathologically, and the results are shown in the lower right. You can see the split in the posterior vitreous cortex, but also the presence of hyalocytes embedded in this tissue. If the split in a vitreoschisis eye occurs anterior to the level of hyalocytes, these cells remain attached to the retina embedded in the collagen matrix of the posterior vitreous cortex, and as mononuclear phagocytes, they attract other cells, particularly monocytes from the blood and glial cells from the retina. These migrate and then proliferate to form a hypercellular membrane that is highly contractile. If, however, the split occurs posterior to the level of the hyalocytes, these cells pull away from the retina along with the rest of the vitreous body, and only a hypocellular thin membrane results, and thus this does not promote either macular pucker or PVR. Anomalous PVD in the periphery with vitreoschisis is demonstrated in this OCT provided courtesy of Michael Engelbert in New York. And here too, splitting anterior to the hyalocytes results in persistent attachment of these cells to the ILM, and they recruit cells from the retina and blood, resulting in the hypercellular contractile membranes that play an important role in proliferative vitreo-retinopathy. So once again, I'd like to thank Professor Lange for inviting me to participate in this very important symposium on hyalocytes in health and disease, and I look forward to the remaining presentations of this symposium. Thank you.